Speaker, Dr. Narendra Babu, MC. He is a professor and former HOD of KIMS, Bengaluru. His areas of interest are obstetric anesthesia, and he had many international and national journal publications. He achieved the gold medal in his postgraduate examination, and he's delivered multiple expert talks at conferences, guest lectures, and CMEs. Dr. Narendra Babu. He will be speaking on uptake and distribution of gases. Dr. Narendra Babu, please.
Good morning. At the outset, I would like to thank the organizers for giving me the opportunity, and I bring my alma mater, Kempegowda Institute of Medical Sciences. Two very expert speakers have started the CME. I don't know, they have done excellently well. I don't know, I may not reach up to their mark, but I'll try to tell. Here I am trying to deliver how uptake of volatile anesthetics and distribution of volatile anesthetics are done. And the gas loss and how vaporizers are there is there. So I feel the input, that is the inspired concentration is good over here with two already good speakers, but the uptake I am not seeing, the postgraduates. No disclosure. So rational administration of anesthesia requires an understanding of factors governing these gradients so that they may be best controlled or accounted for. So with this, I start my introduction. Modern inhaled anesthetics are important pharmacological tools for reversibly altering nervous system functions in patients. Optimal delivery of systemic drugs via inhalation requires a full understanding of the factors influencing how gas phase compounds move into and out of various body tissues and how they are metabolized, that is the pharmacokinetics, together with the knowledge of where and how these drugs and their metabolism affects tissue function. So what is our goal? The goal is delivering inhaled anesthetics is to produce an anesthetic state by establishing a specific concentration of the anesthetic molecules in the central nervous system. That is the central nervous system partial pressure, the partial pressure in the blood and the partial pressure in the alveoli should be equilibrated. So what are our objects today of the discussion? To understand the factors influencing how gas phase compounds move into and out of the body tissues, to understand how they are metabolized, and to understand how their metabolism affects tissue functions. So before going into that, Sir started off remembering 1846. So the same picture in the ether dome which is there. And coming on to the topic per se, inhalational agents are basically divided into volatile agents and gaseous agents. The difference between the volatile agents and gaseous agents, volatile agents are defined by vapor pressure less than 1 atmosphere at 20 degrees Celsius, and their boiling points are always about 20 degrees. Typically compose a small fraction of the gas mixture to be delivered to the patients. Negligible additional effects with volatile anesthetic. These examples include halothane, isoflurane, desflurane, and sevoflurane. Now, nitrous oxide, 1844, even in 2023, it is still there. There is decommissioning of nitrous oxide in some places, but it's still a controversy. Gaseous anesthetics are defined by vapor pressure above 1 atmosphere at 20 degrees Celsius and boiling point below 20 degrees Celsius. Typically comprises a large fraction of an inhaled gas mixture, that is when they exert their concentration effect and the second gas effect. So produce additional effects like this. Examples are xenon and nitrous oxide. Xenon is very expensive. See, the cost is withholding, even though it is an ideal inhalational anesthetics. The theory of, a little bit of theory, unitary theory by Claude Bernard in 1870. Mayer Overton in 1899 and 1901 is the one who said a strong correlation between the anesthetic potency and the solubility exists. And the critical volume hypothesis is also there. But these theories have been further subdivided into macroscopic, where the inhalational anesthetics acts at the brain and the spinal cord, synaptic at the synapses junction and at the molecular level. Synapses is at the axons and the synapses, and molecular level is at the presynaptic and the postsynaptic junctions. So I will go back to partial pressures and vapor pressures once again. Partial pressure is the thermodynamic force for gas transfer between two compartments. A well-described partial pressure was given by my earlier speakers. Anesthetics move from regions of higher partial pressure to low partial pressure, unaffected by the other components of the gas mixture. Equilibrium is achieved when the partial pressure of an anesthetic is equal in the different compartments. The maximum partial pressure of a volatile compound is a vapor pressure, which is very vital when you are using a vaporizer. So hydrophobicity and partition coefficient, I will talk more on partition coefficient because that is what is vital when it is uptake and tissue distribution of the volatile takes place. Is the ratio of two soluble concentrations of equilibrium in two separate but adjacent solvents as compartments, such that as solutes moves freely between the compartments. So anesthetic partition coefficients between blood and gas and between tissue and blood are important factors in uptake and distribution. Inhaled drugs, as they move from pulmonary airspace to pulmonary blood and then from the blood to the various tissues. So biophysical properties of some of the inhalational agents with their discovery time. And now coming into the actual topic per se, barriers to the flow of inhalation agents. So this is a bird's eye view of how exactly an uptake and distribution takes place. So this I have made it made simpler from the machine through the circuit to the lungs, how it goes. Inhalational agents move through most of these barriers before it is uptake. So once again, I simplified, repeated the same slide in a different way, so you can have a better idea when at the end of the talk. So what are the factors that affects the uptake and distribution and release of inhalational anesthetic agents? One is the alveolar concentration. The second one is the drug uptake from the lungs. The alveolar concentration includes, as I started off my talk, is the inspired concentration in the fresh gas, the breathing system per se, the circuit absorption, and alveolar ventilation. Functional residual capacity also plays a vital role. Next, coming on to the drug uptake from the lungs, it depends on the solubility or partition coefficient. Pulmonary alveolar blood flow, when it is normal, it is cardiac equivalent to the cardiac output, and alveolar venous partial pressure gradient is very vital, and second gas effect. So anesthetic delivery from the vaporizer is in liters per minute from a closely approximated as the product of the delivered anesthetic concentration in the fresh glass. This is derived with the equation. Volatile anesthetic delivery is pressure delivered into fresh glass flow into T. T is the time constant. Fresh gas flow washing through the breathing circuits. What happens? Washing gas mixtures delivered from the anesthetic machine replaces gases in the breathing circuit. The factors affect washing are fresh gas flow and the breathing circuit volume. When the breathing circuit volume is on the higher side, the uptake is, the alveolar concentration is delayed, the FA to FI ratio takes a longer time. So to overcome this, we always increase the fresh gas flow. Gas dynamics in the circuit, partial pressure of the gas at the delivery level equilibrates with the partial pressure of the gas in the circuit, affect the given time defined as dP. This is a simple calculation which is not. And now time constant is a very vital thing in uptake and delivery. What is time constant? The time required for flow through a container to equal the capacity of a container. In a 10-liter box, if along with oxygen 5 liter of nitrogen is put, then the time control becomes 10/5:2. That is, at the end of 2 minutes, the nitrogen will be around 2%, and by the end of 4th minute, the time constant will be around 98%. Time constants are shown because this is very, very important. Other circuit factors are affecting equilibrium between vaporizers and the circuit. Absorption from the circuit. Different circuits have different absorptions. Earlier we were using rubber circuits. Now we are using disposable plastics. Rubber circuits absorb the volatiles much more compared to the present circuits. Factors which affect the alveolar concentrations, the inspired concentration, the rate of rise is directly proportional to the inspired concentration, and the alveolar ventilation, the larger the alveolar ventilation, the more rapid the rise in alveolar concentration, that is the FA. Inspired gas is diluted by FRC. When the FRC is more, the alveolar ventilation, the slower the absorption will be there, and the FA to FI takes a longer time. And the time constant, the time, I'm repeating some of the things because it should be taken up before how it actually the volatiles are taken up. So the larger the functional capacity, there is dilution of the functional alveolar concentration. So this coming into the concentration effect. Concentration effect has two things. One is concentrating effect and the other is the augmented flow, gas inflow. The higher inspired concentration results in a disproportionately higher alveolar concentration. The effect is called as the concentrating effect. The higher the Fi, the greater the effect. This can happen only with the gaseous the gaseous agents like nitrous oxide. And the second phenomenon responsible is, since nitrous oxide is taken up by the blood very fast, there is secondary effect which when the flow takes in, the concentration increases. So this is what the slide is normally kept in your exams, concentrating effect and the second gas effect. I'll rush through them because these are two effects which will help you in uptake and distribution. Now coming into the determining by the uptake in the blood. So during inhaled anesthetic induction, anesthetic flows from alveolar gas to, thank you. Alveolar capillary interface is there separating these compartments, and once again the partial pressure is the main gradient between alveolar gas and the mixed venous blood. So what are the factors that help in uptake? Pulmonary blood flow, which is normally, if there are notions, equivalent to the cardiac output. Blood's capacity to salivate anesthetic from gas state, that is partition coefficients. The blood gas, the relative capacity, what is a blood gas partition coefficient? Relative capacity per unit volume of two solvents to hold the anesthetic gas. Example, isoflurane, 1.4 ml means that millimeter of blood holds 1.4 times as much as isoflurane when compared to the alveolar gas. So some of the partition coefficients of different volatiles that have been used now. Effect of blood solubility on the rise of alveolar concentration. The higher the solubility, the slower the time in induction. The lower the solubility, the faster the induction and recovery. And coming into the cardiac output, if there are notions, the flow of blood through the lung determines the amount of blood available to remove the anesthetics. The greater the cardiac output, the faster the uptake of the drug into the blood, so slower the induction. Effects of cardiac output on the alveolar anesthetic partial pressure. And this is a very important thing. The mixed venous anesthetic concentration, the higher the mixed venous concentration, the slower the anesthetic uptake. At equilibrium, the venous pressure should be equal to the arterial partial pressure to the alveolar pressure when the uptake will be around 0. The rate of rise of mixed venous concentration depends on the tissue uptake of the anesthetics. Uptake from the lung, usually this formula holds good. Blood solubility into cardiac output into alveolar partial pressure minus the venous partial pressure by the atmospheric pressure, or to be very precise, the barometric pressure. Factors which affect or decrease, increase or decrease the rate of rise of alveolar concentration to the inspired concentration. When it is increased, low blood solubility, low cardiac output, high minute ventilation, these are some things. High pulmonary arterial to venous partial pressure. These are the factors which are affecting them. And when it comes to shunt, V by Q mismatch, you should always be worried about the pulmonary dead space. Pulmonary dead space troubles you with low soluble agents when the FA is delayed. And right to left shunt, especially transpulmonary or intracardiac. And when we are iatrogenically doing an one lung ventilation, increases the alveolar arterial difference, and these are more affected with less soluble agents compared to the more soluble agent. Left to right shunts does not have any effect on the induction on inhaled anesthetics. Uptake, tissue uptake, the tissue uptake from the lungs, the same factors which govern the uptake from the blood also governs the tissue uptake. The tissue blood partition coefficient, the tissue blood depends on the tissue blood flow, the tissue anesthetic concentration. Tissue uptake of anesthetic is calculated along with the time constant. Time constant equals solubility into volume by flow. So here there are 4 types of different tissues: vessel-rich groups, then muscle group, fat group, and the vessel-poor groups. We are not much worried about the vessel-poor groups, but the vessel-rich groups are the ones which take up at a faster rate. It happens in minutes, whereas the muscle groups takes it in hours compared to the fat groups. In obesity, the fatter people take up more, and prolonged anesthesia causes delayed emergence. But the newer agents like Sevo and desflurane have lesser affinity to the fat, so that is the reason they are used in obese patients. And the time constant for different tissues are shown. And coming to the very vital thing, why the inhalational induction in infants and young children is rapid. The rapid wash-in and wash-out of inhaled anesthetic in infants and young children can be explained by the following factors. They have a greater alveolar or ventilation to FRC ratio. Ventilation to FRC ratio is approximately around 5:1 in neonates compared to adult, where it is 1.5:1. Greater impact, this is more once again on the soluble agent. Greater fraction of the cardiac output. Vessel-rich groups receive greater fraction, but in children, 18% of the body weight there is 18% of the body weight when compared to 8% in the adults. And reduced tissue blood solubility because the water content in the children is more. That is why this is one of the reasons for the earlier wash-in. And reduced blood gas solubility, once again, because it can happen in both the adult as well as children, but in children it is more important because the soluble agents is about 18% less in neonates. It is because they have a lesser serum cholesterol and proteins, including albumin. When there is albumin is decreased, this thing is furthermore potentiated. However, sevoflurane does not have any of this. So sevoflurane is being projected as an ideal volatile in children. And elimination, coming into the elimination, is through recovery, depends on once again the cardiac output, minute ventilation and solubility, diffusion between tissues, and percutaneous and visceral is very minimal. The recovery is not guided by concentrating effect, and the inspiration, can I take another 2 minutes, ma'am? Recovery is not guided by the concentrating effect. So increased solubility slows recovery. Increasing ventilation may help in early recovery from potential inhalational agents. Prolonged anesthetic delays recovery. There is no concentrating effect or emergence. So diffusion hypoxia, a short notes in your examination. This happens because nitrous oxide at the end of the surgery diffuses back into the alveolar and dilutes oxygen. It not only dilutes the oxygen, it also dilutes carbon dioxide, which reduces the respiratory drive. Thereby, when nitrous oxide is being used, especially in compromised patients, post-surgery, providing oxygen for 3 to 15 minutes is very vital. So coming into MAC, MAC has been already explained. MAC is the minimum alveolar concentration of an anesthetic at 1 atmosphere when 50% of the subjects are not responding to a noxious stimuli, that is a surgical incision. So there are different MACs commonly asked in exams: MAC awake, MAC 95%, MAC intubation, and MAC bar. As sir was telling, the recent is the pressure P should be added into this. And the MAC always defines the potency. The lesser the MAC, the more the potent the drugs are. And the factors which are affecting MAC are age. From the first 6 months, around 30% increase is there. Thereafter, it decreases 6 to 7% every decade after 20 years. And drugs like ethanol, amphetamine, all increase MAC. Hyperthermia also increases MAC. Drugs, the factors that decrease are, as I've already told, age and drugs. And factors that does not affect MAC are duration of anesthesia, gender, height or weight, hypothyroid or hypothyroidism. And the take-home message is the clinical effects of inhalational anesthetics are determined by the agent's partial pressures in the brain, which reach equilibrium with the alveoli and blood upon induction. Induction occurs faster with increased delivery and decreased uptake of anesthetics. Anesthetic uptake is determined by anesthetic solubility in the blood, alveolar blood flow, and the difference in partial pressures between alveolar glass and the venous blood. Minimum alveolar concentration is a measure of the clinical effect of the anesthetics and correlates with the potency of the anesthetic agents. With this, these are my references. And this is my alma mater. With this, I thank once again my organizers. And for a patient hearing from my audience, august audience, I thank my chairpersons. Thank you, sir.
Thank you.